Good morning, respected VC sir, Pro VC sir, and MS sir, respected faculty, dear students. In series of our PGCRs, today's PGCR is 19th PGCR, and yet again we are discussing a very important topic in today's PGCR, that is approach to the maculopapular rash. As we all know that the rash is a commonly seen entity in our practices throughout the specialties, and it might be because of some common viral infections or a presentation of a systemic disease. So it requires a proper approach that includes history, examination, investigations, and then after deciding because of what this maculopapular rash is, we can treat the maculopapular rash, because it might be self-limiting or maybe requiring treatment, as it might be because of infections or drug reaction or autoimmune diseases. For today's PGCR, the chairperson is respected Ma'am Manisha Nijavan Ma'am, the head of the Department of Dermatology, and the moderator is Dr. Shivi Nijavan. So over to Dr. Shivi. Thank you.
A very good morning to all the respected dignitaries, colleagues, dear faculty members and juniors. I am Dr. Shivi Nijavan, Assistant Professor from Dermatology Department, and I will be moderating today's PGCR. The topic for today is approach to maculopapular rash. Now, a rash has numerous causes, and the rash itself can be differentiated into, based on the appearance, can be differentiated into a vesicular rash, a petechial rash, maculopapular rash, and so on. But for the sake of simplicity, we will confine our discussion today to maculopapular rash, as it is a most common entity that we come across almost on a day-to-day basis, not just in skin OPD, but also in other departments like medicine, family medicine, rheumatology, pediatrics. So one must know how to approach such a case. But before we move on to today's discussion, we would like to briefly discuss about structure and function of the skin and some basic skin lesions so that we can understand today's topic in a better way. So let me first call upon the first speaker, Dr. Priyanshi Tripathi from Department of Dermatology, who will be discussing about the structure and function of skin and basic skin lesions. This discussion will be followed by approach to maculopapular rash, and it will be taken up by Dr. Ishita Chaudhary from Department of Dermatology. Dr. Arushi Chaudhary will be covering the investigation part, and finally Dr. Kiran Kumawat will be discussing certain clinical scenarios and the respective treatment. So let us begin. Over to you, Dr. Priyanshi.
Good morning, esteemed dignitaries, senior faculty members, and my dear colleagues. I'll be starting with structure and function of skin very briefly. Skin, as we all know, is the largest organ of the body, accounting for approximately 16 to 20% of body weight. It is divided into three layers, the uppermost being epidermis, middle dermis, and lowermost being the dermis. It also has accessory structures like hair and sebaceous gland and sweat gland. Epidermis, the outermost layer of the skin, is composed of stratified squamous epithelium, and the cells present in majority are keratinocytes, namely so after the structural protein abundant in it, keratin. Its thickness varies from 0.4 to 1.5 millimeter. It is further divided into 5 layers as seen in the picture: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Beneath the epidermis lies a vascularized dermis that provides structural and nutritional support. Its thickness varies from 0.5 to 5 millimeter. It is further divided into papillary dermis and reticular dermis. The type of protein fibers that are abundantly found in it are collagen and elastin that are responsible for its structural support. Hypodermis or subcutis, also known as paniculus adiposus, it consists of fibrous septa and lobules. It contains adipocytes that act as insulating layer and also caloric reserve. The foremost function of skin is the barrier. It prevents the inward and outward diffusion of substances, particularly water and electrolyte. It provides barrier from penetration of microorganisms and chemicals, barrier from UV radiations, and also mechanical barrier to blunt traumas and insults. It helps in regulation of body temperature by conservation and loss of heat. Skin, being an immunologically active organ, also has immunological functions. It also synthesizes vitamin D and secretes vitamin E as well. It plays a role in sensory function and also has importance in aesthetics. Diagnosis and treatment of a skin disease requires a physician's ability to recognize the primary skin lesion and the reaction pattern of skin. In this part, we will discuss the technical vocabulary of dermatologic prescription, also known as morphology, as it is essential in generating a differential diagnosis. Starting with the primary skin lesion, a circumscribed, flat, non-palpable lesion with change in color when it's less than 1 cm in size is called as a macule. When it's more than 1 cm in size, it's called as patch. They can be depigmented, hypopigmented, hyperpigmented, or erythematous. A circumscribed, raised, palpable lesion when it's less than 1 cm in size is called as a papule. When it's more than 1 cm in size with change in texture and plateau-like elevation, it's called as a plaque. A circumscribed, elevated, clear, fluid-filled lesion when it's less than 1 cm in size is called as a vesicle. When it's more than 1 cm in size is called as a bulla. Pustule is superficial collection of pus in an elevated lesion. An abscess is a collection of pus in deeper skin and tissues. Extravasation of red blood cell in dermis produces non-blanching lesions which are called as patechi when they are less than 4 mm in size, purpura when they lie between 4 to 10 mm, and ecchymosis when they are more than 10 cm in size. Now, starting with the secondary lesions, a scale is abnormal shedding and accumulation of stratum corneum in visible scales. Crust results from dried blood, serum and other exudates on the surface of skin. Atrophy refers to the reduction in component of epidermis, dermis or subcutaneous tissue. Excoriation results from exogenous injury to the epidermis, mainly from scratching, and they are characteristically linear. Erosion is partial loss of epidermis, whereas an ulcer is full thickness loss of epidermis with or without dermis or subcutis. Fissures are linear clefts in skin. Now I would like to call upon Dr. Ishita to take you further on the discussion of maculopapular rash and how to approach it.
Thank you, Dr. Priyanshi. Good morning, respected dear faculty members, seniors and colleagues. Now coming to the today's topic, which is very commonly seen in our OPDs, that is maculopapular rash. Firstly, what is a maculopapular rash? Skin eruptions which are characterized by a combination of erythematous macules and papules. An average number of patients attending to the OPD with maculopapular rash presentations are 2 to 3 patients per day. We tend to confuse with two entities very oftenly in our OPDs because of their similarity in appearance, but actually they have a different morphology. First one is urticaria, in which there is itchy red colored wheals which appear and last for very short duration. Second one is vasculitis, in which there is petechial or purpuric rash which appears, and it appears on lower leg, and it is non-blanchable, whereas in maculopapular rash is blanchable. Maculopapular rash can be due to two different causes, like firstly infectious, in this viral or bacterial. In non-infectious causes, it can be due to drugs, autoimmune causes, or others like Kawasaki disease, acute graft versus host disease, or Still's disease. Viral causes include measles, rubella, chikungunya, dengue, COVID, or HIV infection. Bacterial causes include scarlet fever, staphylococcal scalded skin syndrome, syphilis, rickettsial fever. Drugs include exanthematous drug eruption, erythema multiforme, drug rash with eosinophilia, and systemic symptom. Stevens-Johnson syndrome and toxic epidermal necrolysis. Autoimmune diseases contains systemic lupus erythematosus or dermatomyositis, and others may include Still's disease, Kawasaki disease, or acute graft versus host disease. To approach a case of maculopapular rash, we start with history taking, then we do physical examination and make a provisional diagnosis. Then with the help of laboratory investigations, we come to a definitive diagnosis. So, in history taking, we firstly consider the age, as viral exanthems are very common in pediatric population, such as measles or rubella. In adult population, we commonly encounter drug-induced reactions, which can be due to antibiotics, NSAIDs, or antiepileptics. Season also plays an important role, as measles and rubella peak during winter season, whereas dengue and chikungunya peak during rainy season. Now the duration of rash. A rash can have an acute presentation, which can be seen in infective causes and drugs, and it has a chronic presentation in non-infective causes such as autoimmune diseases. Day of rash appearance in a febrile patient. There is a mnemonic, that is, a very sick person must take double tablet. On day first, after the fever, rash appears in case of varicella. On day 2, it appears in scarlet fever or staphylococcal scarlet skin syndrome. On day 3, it used to appear in smallpox. On day 4, in measles. On day 5, in typhus. On day 6, in dengue. And on day 7, in typhoid. The rash may appear on same day or one day after in case of rubella or chikungunya. It may appear with fever or later in case of infectious mononucleosis. It is variable, but often with fever in case of COVID infection, and weeks to months later in HIV infection. Day of rash appearance after drug intake. In exanthematous drug eruption, we see rash appearance after 4 to 14 days. In erythema multiforme, it appears 1 to 3 weeks later. In Stevens-Johnson syndrome or toxic epidermal necrolysis, the rash may appear 1 day or 3 weeks later. In drug rash with eosinophilia and systemic symptom, it takes 2 to 8 weeks to appear. Now the associated symptoms. Fever with its onset, duration and type, also presence of cough or coryza, redness or watering of eye is commonly seen in viral exanthem or Kawasaki disease. Itching and burning sensation is commonly associated with drugs and autoimmune diseases. Mucosal involvement can be seen in infections, drugs, autoimmune diseases. Now the exposure history, which also plays an important role, as history of recent infection or travel to an endemic area or insect bite plays an important role to diagnose dengue or rickettsial fever. History of contact with sick individual plays an important role for measles and rubella. History of new medications or vaccination or history of environmental or chemical exposure is important. Now in medical history, we ask for the immunization status of the patient, also history of diabetes, hypertension, asthma, tuberculosis. Sexual history is important for sexually transmitted infection, as in secondary syphilis or HIV infection. Family history should be taken for the contact history and history of autoimmune diseases in family. Now, coming to the physical examination, firstly we take general physical examination. General appearance of the patient and vital should be noted. Pallor, jaundice, cyanosis, clubbing, edema should be ruled out. Now, in the mucocutaneous examination, we look at the rash. Its morphology, as maculopapular rash is the basic presentation. Then its sites of onset, its duration and distribution, and direction of spread should be noted. Now the distribution of the rash. It is central in case of measles, rubella, infectious mononucleosis and HIV. It is peripheral in erythema multiforme or COVID infection. Palm soles involvement is seen in secondary syphilis or erythema multiforme. Associated systemic signs should be noted, as lymphadenopathy is an important factor. In rubella, we see occipital lymphadenopathy or cervical lymphadenopathy. In HIV infection, we see generalized lymphadenopathy, and in syphilis cases, we see inguinal lymphadenopathy. Hepatosplenomegaly can be seen in cases of dengue, chikungunya, measles, rickettsial disease, or DRESS syndrome. Arthritis is a common presentation in case of chikungunya, dengue, connective tissue diseases, and Still's disease. Now I would like to call upon Dr. Arushi from the Department of Internal Medicine to continue further about the laboratory investigation.
Thank you, Dr. Rishita. A very good morning to respected dignitaries, teachers, and my dear colleagues. So, after a thorough history taking and physical examination, which are very crucial for diagnosing a maculopapular rash, the next step primarily involves investigations to determine the underlying cause. First, we'll start with basic laboratory tests such as CBC that help assess the overall health status and provide initial clues about the possible cause of the rash. Second is inflammatory markers such as ESR in CRP, which are elevated in inflammation, infections, or in autoimmune diseases, and liver and kidney function tests. Second is infectious workup, which often these tests help identify specific pathogens responsible for fever and systemic infections. First is viral serologies. We can do it for measles, rubella, Epstein-Barr virus, bacterial cultures or PCR for suspected pathogens, rapid plasma reagent or venereal disease research laboratory tests for syphilis, HIV testing, and blood and throat cultures for streptococcal infections. Next is an autoimmune workup. It primarily involves testing for anti-nuclear antibodies, which are autoantibodies that target the cell nucleus and are commonly associated with autoimmune diseases. A positive ANA test indicates an autoimmune response but requires further testing such as anti-double-stranded DNA and extractable nuclear antigens for specific disease diagnosis. For further investigation, if needed, a skin biopsy may be performed. Now, leukopenia. Now we will coming to complete blood count. First is leukopenia, which is characterized by a decrease in the white blood cell count, and it is commonly associated with viral infections such as dengue, chikungunya, measles, and rubella. Second, leukocytosis, which refers to an elevated WBC count, and it is typically seen in bacterial infections and certain viral infections like Epstein-Barr virus infection, which commonly causes infectious mononucleosis. Third, thrombocytopenia or low platelets, which is there in viral infections such as dengue, chikungunya, measles, and rubella, and rickettsial infections such as in scrub typhus. Fourth, thrombocytosis, which is elevated platelets, which is again common in infections, inflammation, and drugs. Now coming to differential counts, first is lymphocytosis, which is increased lymphocyte counts, and it is commonly observed in viral infections such as dengue, chikungunya, and measles, and can also be associated with atypical lymphocytosis as seen in infectious mononucleosis. Second is lymphopenia or decreased lymphocyte count, and it is often found in viral infections such as in COVID-19 infection and in conditions involving immunosuppression such as in HIV. Next is eosinophilia, which is marked by an elevated eosinophil count, and it is frequently linked to drug reactions including DRESS, that is drug reaction with eosinophilia, and systemic symptoms, and neutrophilia, which is characterized by elevated neutrophils, and it is typically associated with viral infections. Next is ESR, erythrocyte sedimentation rate, and C-reactive protein. These are, however, non-specific markers, but when elevated, so they support inflammatory or infectious etiology. Elevated and of these tests, CRP may be a better marker of disease activity since CRP changes in response to inflammation faster than ESR. Elevated ESR and CRP is found in inflammatory or in infectious causes such as in viral infections, bacterial infections, or in autoimmune causes. However, normal ESR in CRP is found in non-inflammatory causes such as in drug reactions. Now coming to specific tests. First is for viral infections, we go for serological tests. They play a crucial role in diagnosing viral infections by detecting antibodies or antigens in a patient's blood. First, measles, mumps, rubella, and Epstein-Barr virus infections are diagnosed by detecting IgM and IgG antibodies, which help differentiate between recent and past infections. Second is dengue infection, which can be identified using the NS1 antigen which for early detection, while IgM and IgG antibodies confirm an ongoing or previous infection. Chikungunya is primarily diagnosed by detecting IgM antibodies. HIV, the diagnosis involves ELISA testing followed by a confirmatory Western blot or a PCR to ensure accuracy. COVID-19 is detected using reverse transcriptase PCR, which is viral RNA with high sensitivity. Now, lastly, the molecular tests are available for specific viruses including dengue, chikungunya and coronaviruses to provide precise and early diagnosis. Now, now coming to the bacterial infections. So first is serological tests for syphilis and include the rapid plasma reagent and the venereal disease research laboratory tests, which are non-treponemal screening tests to detect an active infection. However, to confirm the diagnosis, tests such as TPPA, that is treponema palladium particle agglutination, and other treponemal tests such as enzyme immunoassay and chemiluminescent immunoassay and an antibody absorption test are done, which are treponemal tests and specifically detect antibodies against the treponema palladium. For rickettsial diseases like scrub typhus, the presence of IgM or IgG antibodies aids in the diagnosis. Second, cultures. Now, cultures-based diagnostic methods including throat swabs for detecting streptococcal infections such as in scarlet fever. In cases of staphylococcus scarlet skin syndrome, the swabs are collected from multiple affected sites, which help confirm the presence of Staphylococcus aureus. Now, for the drug-induced causes, first, they are elevated in cases of drug hypersensitivity. First is eosinophil count, which is elevated in drug hypersensitivity reaction. Skin biopsy is only performed for suspected Rett syndrome or is only performed for suspected Rett syndrome, Stephen-Johnson syndrome, or in toxic epidermal necrolysis or other drug-induced rashes and in autoimmune diseases. Drug patch testing is used to identify specific drug allergies. Now, others. First, adult onset Still's disease. It is characterized by an elevated erythrocyte sedimentation rate, C-reactive protein, elevated serum ferritin, mostly more than 3000, neutrophilic leukocytosis, anemia, thrombocytosis, which is again reactive. Second, Kawasaki disease, which is characterized by elevated ESR, CRP, anemia, lymphocytopenia, and thrombocytosis, which is again reactive. And now next, autoimmune diseases. An autoimmune panel includes ANA for detecting autoimmune activity, anti-double-stranded DNA for diagnosing systemic lupus erythematosus, and inflammatory markers such as ESR and CRP to assess systemic inflammation. Additionally, complement levels are measured as the reduction is indicative of lupus and other immune complex diseases. Now, in systemic lupus erythematosus, anemia, which is hemolytic, or leukopenia, or lymphopenia, or thrombocytopenia can be seen, and additionally, we can also see pancytopenia due to bone marrow suppression or immune-mediated destruction. Now, coming to the imaging studies, a chest X-ray can help identify pulmonary manifestations of various infections such as pleural infection in dengue, like as in the first chest X-ray, we can see there is an obliteration of the right costophrenic angle, which is a pleural effusion, and it is commonly found in dengue. Interstitial pneumonitis in measles, and both pleural effusion and acute respiratory distress syndrome in complicated cases of scrub typhus. In COVID, however, bilateral peripheral ground glass opacities, as it is seen in the third chest X-ray, or patchy consolidations can be seen. Second is ultrasound abdomen to look for hepatosplenomegaly, which is commonly found in the cases of scrub, DRESS, dengue, chikungunya, and measles. Now, coming to the management, first is general supportive measures. Now, proper hydration is essential to prevent dehydration, especially during febrile illnesses, by ensuring an adequate fluid intake. For fever management, antipyretics such as paracetamol, which is acetaminophen, are recommended to reduce fever and discomfort. However, NSAIDs like ibuprofen should be avoided in suspected dengue cases due to the increased risk of bleeding. Skin care should include the use of mild cleansers and emollients to maintain skin integrity, and scratching should be avoided to prevent secondary infections. Isolation precautions are necessary for contagious diseases like measles and rubella to prevent the spread of infection to others. Thank you. Now I would like to invite Dr. Kiran to discuss the clinical manifestation and specific treatment.
Thank you, Dr. Arushi. Good morning, respected faculty members, seniors, and colleagues. I would like to discuss about some common diseases presenting with maculopapular rash. When a patient presents with history of fever, constitutional symptoms, rash in a pattern progression, relative absence of pruritus, with or without seasonal occurrence, then the viral causes of maculopapular rash could be dengue, chikungunya, infectious mononucleosis, measles, rubella, coronavirus disease, and human immunodeficiency virus. We have a case scenario where the maculopapular rash appeared 3 to 5 days after fever and persisted for 7 days. It had a centrifugal progression and a chick sign was seen as seen in the image, which is a hyperpigmentation at the tip of nose. Also, Edisonian hyperpigmentation was seen in the creases along with arthralgia. I would like to ask the audience, on the basis of these features, what would be the possible diagnosis? Exactly. It is chikungunya, which is treated by supportive care, and symptomatic treatment is given for fever and joint pain. Moving on. In another case, a patient presented with biphasic fever, retrovulvar pain, myalgia, arthralgia, that is breakbone fever, and the rash appeared 3 to 5 days after fever. And as seen in the image, there was generalized erythema with islands of normal white skin, which is called white islands in sea of red, and had complications like severe hemorrhagic manifestations in the form of purpura, ecchymosis, and active bleeding. What is the likely diagnosis? Exactly, it is dengue, treated with supportive care, and monitoring of hematocrit, platelet count, and signs of shock is done, and NSAIDs are to be avoided. If the patient has a history of direct contact with infected person's bodily fluids, along with pharyngitis, palatal petechiae and uvular edema, along with periorbital edema called as Hoagland sign with lymphadenopathy, then these features are suggestive of infectious mononucleosis, which is treated with supportive care, and a short course of corticosteroid is given in case of complications. If the rash begins retroauricularly and from anterior hairline, has a centripetal progression with punctate white lesions seen over buccal mucosa called Koplik spot as seen in the image, these features point towards measles, which is treated with supportive care, hydration, and vitamin A supplementation. If the maculopapular rash has light pink macules or papules and the rash first appears on the cheek and retroauricular area, it has a centrifugal progression with Forsheimer spots, which are rose pink petechiae present over the soft palate and uvula, and cervical and occipital lymphadenopathy, then these features point towards rubella, which is treated with supportive care. Fever, weight loss, night sweats, myalgia, lymphadenopathy, and a transient rash with pharyngitis, oral ulcers, oral thrush as seen in the image, diarrhea, and diffuse alopecia point towards HIV, and the treatment is antiretroviral therapy along with supportive care. When chilblain-like lesions start on the acral site as seen in the image, along with maculopapular lesions with multi-system involvement, then these features are suggestive of coronavirus disease, and the treatment is supportive along with antivirals, which are given in severe cases. When a patient presents with history of fever, constitutional symptoms, maculopapular rash, and relative absence of pruritus, then the bacterial causes could be scarlet fever, staphylococcal scalded skin syndrome, syphilis, and rickettsial infections. When a child presents with history of localized staphylococcal infection elsewhere, widespread red eruption which are accentuated in flexures, thick crusting and fissuring around the eyes, nose and mouth, and sheets of epidermal detachment seen in the form of potato chip detachment with Nikolsky sign positive, that is when the shearing force dislodges the upper epidermis from the lower epidermis, which is done by thumb, then these features point towards staphylococcal scalded skin syndrome and the treatment is supportive and both topical and systemic antibiotics are to be given. A child presenting with flushed face, relative pallor around the mouth, with white strawberry tongue and the rash appears on the second day after fever and there are 5 fine red punctate lesions giving a sandpaper appearance along with pastia lines which are seen in the flexures due to capillary fragility, then these features point towards scarlet fever which is treated with antibiotics and symptomatic treatment is given. In this case, an adult presented with history of ulcers over the genitals. There was a copper colored rash as seen in the image with papules over palms and soles with colrate of scales known as Bayet's colrate and a moth-eaten alopecia and snail track oral ulcers. What is the likely diagnosis? The treatment is intramuscular benzathine penicillin. When the rash appears after 7 days of fever and there is an ishar at the bite mite site along with tender lymphadenopathy, muscle pain, cough, GI symptoms, hepatosplenomegaly and encephalitis, then these features point towards scrub typhus treated with doxycycline and supportive measures are given. If a patient presents with history of drug intake, maculopapular rash and pruritus, then drug-induced causes would be thought of like exanthematous drug reaction, erythema multiforme, drug rash with eosinophilia and systemic symptoms, Stevens-Johnson syndrome or toxic epidermal necrolysis. When the rash starts appearing within 1 to 3 weeks of drug intake and it starts as bright red macules forming typical target lesions as seen in the image, a target lesion has concentric rings with a darker inner circle and a pale edematous middle ring and an erythematous halo outside. Then these are the target lesions and they initially involve the palms and soles. There is also a prodromal phase of itching and burning along with painful oral ulceration, hemorrhagic crusting and odynophagia. These features are suggestive of erythema multiforme treated with stopping all the drugs, supportive care and corticosteroids. If the maculopapular rash first appears on the trunk and later becomes confluent and generalized involving palms and soles, mucous membranes are spared and systemic involvement is generally not seen, then these features point towards exanthematous drug reaction and treatment is same. When the rash appears after 2 to 8 weeks of drug intake and there is a generalized erythema on face, trunk and upper extremities and the lymph nodes are enlarged along with systemic involvement seen in the form of liver and hematological abnormality in form of eosinophilia, then these features point towards DRESS and treatment is same. Coming on to the more severe form of drug reaction, in this case scenario, a patient presented with a prodrome of fever, upper respiratory tract infection, conjunctivitis and flat atypical target lesions associated with pain and burning sensations. Flaccid blister formation was there and sheets of epidermal detachment less than 10% of body surface area along with detachment of mucous membrane was seen and systemic involvement was seen later. Can anybody tell me what is the likely diagnosis? Right, Stevens-Johnson syndrome. It is treated by hospitalization, stopping the culprit drug and supportive care, corticosteroids and immunosuppressants. The other causes for maculopapular rash are Kawasaki disease, acute graft versus host disease, adult onset Still's disease, systemic lupus erythematosus and dermatomyositis. In this case scenario, a child presented with high-grade fever, sore throat, erythema with cracking of lips and strawberry tongue, bilateral bulbar conjunctival injection with limbal sparing, maculopapular rash, erythema and edema of hands and feet, unilateral cervical lymphadenopathy of size more than 1.5 centimeter. I would like to ask the pediatric resident, what is the likely diagnosis for this case? It is Kawasaki disease, which is treated with supportive care, intravenous immunoglobulins, aspirin, corticosteroids, and echocardiography is done to monitor coronary artery aneurysms. In cases where there is a history of hematopoietic stem cell transplantation and skin is the first and most commonly involved organ, and the rash starts appearing within 3 weeks of transplantation, and it can be itchy and painful, involving palms, soles, and earlobes, and GIT and liver involvement is also seen, then it points towards acute graft versus host disease treated with NSAIDs, corticosteroids, or biologics. A reproductive age group female presented with malar rash, photosensitivity, recurrent oral ulcers, and systemic involvement was seen in the form of arthritis, nephritis, pericardial effusion or endocarditis, and pleuritis. What is the likely diagnosis for this case? It is systemic lupus erythematosus, and the treatment is corticosteroid, hydroxychloroquine, and photoprotection. In another interesting case scenario, heliotrope rash was seen on the upper eyelids, which is a confluent macular violaceous erythema. CMVE was seen on the knuckles, which is called Gottron's papule. CMVE on the upper back and upper arms is called Scholl sign, and Holster sign is the CMVE present on the thighs, along with proximal muscle weakness. Likely diagnosis? Yes, it is dermatomyositis treated with corticosteroids and disease-modifying anti-rheumatic drugs. Now, taking this discussion further, I would like to invite Dr. Shivin ma'am.
Thank you, Dr. Kiran. So, this was quite an elaborative discussion on maculopapular rash and how we should approach such a case. But to be concise, there are few points that we can take away from this entire discussion. When a patient with maculopapular rash presents to us, we should always see that if he or she is presenting with fever or without fever. So when a patient presents with maculopapular rash and fever, fever of recent onset along with prodromal symptoms like cough, conjunctivitis, etc., we think of infective causes which are to be further evaluated. Then if the fever is long-standing one along with systemic symptoms like joint pains, photosensitivity, and some specific rash, it definitely points towards an autoimmune cause. Specifically, painless oral ulcers suggest systemic lupus erythematosus, and proximal muscle weakness suggest dermatomyositis. Again, they have to be evaluated further. Then, if the patient gives a classical history of drug intake prior to the onset of maculopapular rash, we would definitely think of a drug-induced rash, which can vary in severity as discussed in the clinical presentation earlier. And then again, if the patient gives a history of a transplantation followed by maculopapular rash, then we suspect acute graft versus host disease. Coming to the laboratory investigations, Dr. Arushi discussed quite in detail about the whole battery of investigations that we can think of, but definitely we should tailor our laboratory investigations according to the suspected cause, the clinical scenario. Broadly speaking, CBC, complete blood count, gives a whole blood picture, overall blood picture, and it can tell us a lot. Along with that, acute phase reactants like CRP and ESR also, they can point towards an inflammatory cause. Coming to differential counts, which tell us about the different subset of WBC, we should look for neutrophilia. Now, neutrophilia points towards bacterial infections, which are to be further confirmed by serology and cultures. Then coming to eosinophilia, eosinophilia is definitely associated with some drug-induced rash. Lymphocytopenia indicates towards some form of immunosuppression such as HIV, and HIV further has to be confirmed with the help of ELISA. Certain viral infections present with lymphocytosis and thrombocytopenia, and we need to confirm them with further investigations like PCR and serology tests. Coming to RBC, anemia and a picture of pancytopenia can be seen in autoimmune causes like SLE, dermatomyositis, and a full ANA profile must be done to evaluate. The prognosis and diagnosis all depends on ANA profile. So this was the whole summary of today's discussion, and I would like to conclude. What fever is to a physician, a rash is to a dermatologist. So what is a rash? It is a diagnostic clue to an underlying pathology that is happening within the body. And rash, as we discussed in our presentation, has numerous causes, and it can vary from a simple self-limiting rash to a grave clinical picture, such as discussed in Stevens-Johnson syndrome and toxic epidermal necrolysis. Every rash has a story to tell, and we should unfold this story by a vigilant history-taking, clinical examination, and a thorough investigative workup. So I urge everyone, especially the medicine residents, to approach this case with a very broad horizon, thinking of all these clinical presentations and the respective treatment. Thank you. We are very thankful to Chairman Sir, the management team, the PGCR committees for their extensive inputs and their time, and the Department of Internal Medicine. Thank you.